and acute health harms. But we know that in addition to this high burden, that it is disproportionately impacted across a number of populations, including those who are from lower socioeconomic position. Socioeconomic position refers to social and economic factors that influence what positions individuals or groups hold within the structure of society. And so evidence from recent meta-analyses in systematic review show that the risk of alcohol attributable mortality was 3.8 to 5.2 fold higher, depending on the indicator, in individuals with low compared to high socioeconomic position. So very strong social inequities in alcohol attributable harms. Next slide, please. To better understand the potential mechanisms, we can use a conceptual framework proposed by Whitehead et al. On the health impact of social position. So on one line of inquiry in this framework, it considers an individual's social position and how that position influences their exposure to important health risks. This can happen through differential exposure, which acknowledges that different social positions may carry different probabilities of being exposed to specific health hazards. So here in our example today would be alcohol use. And a second pathway through differential vulnerability, where the size of the effect of certain risk factors or conditions will often depend on the presence of other contributing cause. So here we can think about this at a given level of alcohol use, that individuals from low and high socioeconomic position would have different risk of health outcomes. Next slide, please. The social perspective focuses on how the prevailing social context interacts with and influences the pathways from social position to poor health. Social context is taken to mean the interwoven elements of the political, cultural, social, economic environment which characterize a society. So we can think about this influencing this pathway through potentially three different arrows. The first A, whereby policy may influence social position individuals occupying the society directly. Through B, where policy may influence exposure to health hazards faced by people with different social positions. So here we can think about things like different drinking environments, cultures, alcohol quality, and increased alcohol availability in low-income neighborhoods. Third, or through C, policies may influence the effect of being exposed to a hazardous factor and your likelihood of having a health outcome afterwards. And so we can think about differential access to healthcare. Next slide, please. Much of the research to date has focused on the potential differential exposure to alcohol hypotheses or pathway. And this makes a lot of sense, as we might expect that those populations who have higher levels of alcohol use would experience differential or higher levels of alcohol harm. And this is very much the case for men, for example, who consume more alcohol and experience a larger percentage of alcohol harm compared to women. This is not, however, observed across socioeconomic position, which has led to the identification of the alcohol harm paradox, which is found in high-income countries and is defined as individuals with lower compared to higher socioeconomic position experiencing disproportionately greater alcohol attributable harm, despite similar or less alcohol use. So again, evidence from meta-analyses and systematic review showed that heavy episodic drinking could only account for up to 30% in volume of alcohol use, could account for up to 15% of the inequity between socioeconomic position and alcohol attributable mortality. And there's a lot of literature that's tried to explore potential mechanisms leading to this relationship. Including, you can think about differential exposure to a number of factors, including individual lifestyle risk factors, different contextual factors across socioeconomic position, different life course disadvantage, and things like access to healthcare, differential upstream factors, thinking about things like structural or even the exposure to employment opportunities, and even a potential line of inquiry through that the association is artifactual, things like measurement error or underreporting, which are all common in alcohol epidemiology. Next slide, please. However, less attention has been paid to the differential vulnerability to alcohol, which would mean that at a given level of alcohol use, that individuals with low socioeconomic position would experience greater harm than those with high socioeconomic position. And there is emerging evidence indicating a potential joint effect, whereby which when low socioeconomic position and higher alcohol use happen together, you would have an interaction effect or higher than expected level of risk. Next slide, please. So this led to the main objective of our study, which was to estimate the sex and gender specific joint effect of education and alcohol use, looking at both heavy drinking and volume of alcohol use on 100% alcohol attributable hospitalization and death. Next slide, please. We conducted this research using data from the Canadian Community Health Survey, which was linked to health administrative data for follow-up by Statistics Canada. This data set included the pooled respondents from a number of CCHS surveys that were followed up through administrative data to examine things like hospitalization through the discharge abstract database in the Ontario Mental Health Reporting System, and also deaths through the Canadian Vital Statistics database. This novel data linkage includes individual level measures of socioeconomic position, alcohol use, and up to 15 years of follow-up for alcohol attributable harms to look at the potential study objective. In the study population, we pooled individuals from the 2000 to 2008 CCHS surveys with a few notable exclusions, including individuals from Quebec, where we were missing follow-up and administrative data. Those from the 3 territories and health regions where the alcohol use module was not included in the CCHS. Any individual who experienced 100% alcohol attributable harm prior to their CCHS interview. And then age restrictions where we excluded anyone under 15 to be consistent with other alcohol harm literature, and anyone who was over 65 at baseline. And the reason for this exclusion being that this population reports reduced alcohol use, which could lead to a biased measure of lifetime alcohol use overall. So this gave us a study population of roughly 200,000 Canadians. Next slide, please. The main study outcome was incident 100% alcohol attributable hospitalization or death, which we defined using the conditions entirely caused by alcohol indicator from the Canadian Institute for Health Information. Sorry, one more slide. One slide up front of you. Yep. We use this indicator to be consistent with other literature of alcohol harms in Canada. And it uses diagnostic codes listed as either the underlying or contributing cause, and included outcomes such as medical harms due to alcohol, acute intoxication, harmful use, dependence, withdrawal, mental health, and mental and behavioral disorders due to alcohol, and alcohol liver disease. Next slide, please. We operationalized socioeconomic position using 4 categories of educational achievement. We also conducted sensitivity analyses looking at household income quintile, but this harmonized indicator was only available on a smaller number of CCHS surveys. So we prioritize education as our main exposure. Next slide, please. And we had 2 measures of self-reported alcohol use. The first, heavy episodic drinking, was defined as binge drinking or consuming over 5 standard drinks on a single occasion, at least monthly in the past year. And the second was volume of alcohol use, which we defined to be consistent with continuum of risk in Canada's guidance on alcohol and health, based on the number of standard drinks consumed in the past day that were reported. Next slide, please. In the CCHS, sex was measured based on a respondent's self-reported question, whether or not they were male or female. And we recognize that this characterizes biological constructs, although we feel that the way it was asked likely captured both biological and sociocultural aspects. So therefore, in the study today, we use the term sex, gender, women, and men when we're interpreting our findings. And this is to acknowledge important sex differences, which include differences in alcohol absorption, metabolism, distribution, which lead to females experiencing greater harm for the same level of alcohol, in particular when that's over 6 drinks per week. And also the gender differences that are socially constructed, including roles, attitudes, and expectations that are entangled both in the relationship between alcohol use and harm. and that these factors are further compounded at the intersection of sex and gender and education, and that's why we examine these effects stratified by these factors. Next slide, please. We adjusted for potential confounders, including age, marital status, immigrant status, province, rurality, and survey cycle. Next slide. And had three main statistical analyses. The first, we assessed sex and gender-specific prevalence of heavy drinking and volume alcohol use by education. We then estimated the association between education and alcohol attributable hospitalization and deaths, while accounting for competing risks for all-cause mortality. And then third, we examined the joint effect by testing an interaction between education and alcohol use. And in this analysis, we further dichotomized education to improve our precision around the interaction effects. And the formal interaction was measured on the additive scale using the synergy index. And what this measure is the joint relative effect of the two exposures when they happen together, so low socioeconomic position or education and high alcohol use, over the sum of the relative effects of each exposure independently. So because this is a ratio between those two measures, an S value of over 1 indicates a super additive interaction between the exposures, or higher than we would expect when we looked at each of these factors happening independently. Next slide, please. So in this slide, we're looking at heavy episodic drinking by education, where we found that the highest prevalence of heavy drinking was in individuals in the middle categories of education, so high school diploma and some post-secondary groups. Overall, we found a higher prevalence of heavy drinking in men compared to women, which is consistent with other literature. Next slide, please. In this slide, we're looking at the volume of alcohol use by education by men and women separately. And overall, we see the prevalence of medium and high volume alcohol use increase with higher education, so higher levels of drinking with higher education, up until the excess volume category, where men with a bachelor's degree or above had slightly lower prevalence with no association in women. Next slide, please. Here's a table looking at the association between education and alcohol attributable hospitalization and death, where we find an inverse gradient pattern between these factors. Looking at the lowest level of education, the less than high school group compared to bachelor's degree above, we see roughly threefold increased risk in both men and women. And these models were adjusted for, they're the fully adjusted models, including the confounders. Next slide, please. And I'll take a second to orient you to this slide on the joint effect of education and heavy drinking. The results here are included for both men and women separately, with heavy drinking status stratified by high and low education. Next slide, please. So here I'm just showing an example where we see that at each level of heavy drinking, that individuals with low education experience greater alcohol attributable harm compared to those with higher education. This also happens in the absence of heavy drinking if you look just above the red box. And next slide, please. So I'm just drawing your attention here to that the S values were over 1 for both, and these relationships were consistent for both men and women. Next slide, please. So this is a similar plot looking at the joint effects between education and volume of alcohol use. So slightly just more categories because there was no more categories of alcohol use. Next slide, please. You'll see that the results are very similar. And then here looking at the excess volume, you see that, again, that relationship where within a strata of alcohol, that individuals with low education had experienced increasing harm. And next slide, please. And here again, just flagging the S values over 1. So we find evidence of a joint effect. The relationships are similar in women, with notably wider confidence intervals, just due to the fact that there was much fewer outcomes in this population. Next slide, please. So overall, in a large longitudinal cohort with over 15 years of follow-up in Canada, we found a strong association between low socioeconomic position and alcohol attributable harm. We didn't find a differential exposure to alcohol across socioeconomic position, but we did find a joint effect between low education and both heavy drinking and volume of alcohol use in both men and women on alcohol attributable hospitalization and death. So some evidence of a differential vulnerability to alcohol hypothesis. Overall, based on these findings, population level interventions are urgently needed to reduce both the high burden, but also that consider the social inequities and alcohol attributable harms. Next slide, please. And our study has a number of limitations. Many of them are common in observational research, including non-response bias, whose individuals may have higher levels of heavy drinking and volume of alcohol use. There's also maybe selection bias with the exclusion of hard to reach populations from the CCHS sampling frame who may have higher levels of alcohol use. And we can think about individuals experiencing homelessness here. There's also measurement error related to the self-reported measures, which likely lead to underestimates of alcohol use compared to alcohol sales data. This can be between only represent 30 to 60% of alcohol sold. However, in the literature, there's no evidence currently that this is differential across socio-demographic factors. We also note that we only had alcohol use at one measure in the life course, and that therefore life course alcohol use may be not represented in our findings. And finally, true socioeconomic inequities and alcohol harm are likely underestimated, as partially attributable health harms and non-health harms are not included in our outcome. Next slide, please. So just briefly in terms of implications, and if we can think back to the conceptual framework, we can think about three potential areas of alcohol policy that may be effective in reducing social inequities and alcohol harm. The first here are those policies that directly influence those social determinants of alcohol use and harm, the very factors that accumulate over the life course that influence risk of the alcohol harm. Next slide, please. The next category, you could think about alcohol policies that have a disproportionate effect. They therefore reduce alcohol use more in those populations experiencing the inequities. And I think Carolin's going to talk a little bit about this in her presentations. Next slide, please. And the final, just the idea of the interaction of the joint effect would mean that any alcohol policy on the population level reducing per capita alcohol could have important implications for reducing social inequity because there's additional harms in those populations. And you can think about any population level alcohol policy that we know that is effective for reducing per capita use. Next slide. So yeah, that's it for me. So thank you very much for your attention. This study was published last month in Epidemiology and is available. So I put the reference here for your, if you want to give it a read. So thank you very much.
Great. I'll just unmute myself here. So my name is Claire Benny. Again, I'm a postdoctoral fellow at Public Health Ontario, and today I'm going to be talking about investigating income inequality and deaths of despair in Canada. Next slide, please. So first and foremost, I wanted to mention that these papers are available online via the Journal of Epidemiology and Community Health. If you're interested in learning more, the DOIs are available there. If you're not able to access these papers, please send me an email at claire.benny@oahpp.ca. Oh, next slide, please. Great. So I'd like to acknowledge that while I am now affiliated with the folks in Toronto at Public Health Ontario, this work specifically was conducted in Edmonton at the University of Alberta. So I'd like to respectfully acknowledge that we were located on Treaty 6 territory, which is a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence the vibrant community around the University of Alberta. I would also like to thank my co-authors who are listed on this slide. If I could just get the next slide here. All right, so once again, this work was focused on income inequality and associations with deaths of despair and hospitalizations of despair. So what really is income inequality? Well, income inequality is the gap between the highest and lowest earners within a given area. Income inequality is typically measured as Gini coefficient, which is a scale from 0 to 1, with 0 indicating perfect equality and 1 indicating perfect inequality. So the greater the difference between the higher and lower earners in a given area, the greater the Gini coefficient. Now, studies of income inequality in Canada are less common than they are in, say, the United States, because there's some assumptions that economic inequalities are not as diverse or varied here, but that is not necessarily the case. So this here is a map of Toronto and surrounding areas, and it's unsurprising that the highest levels of income inequality seem to be centered right around here because of the wide variety of incomes in these spaces. Just in general, urban cities tend to have higher levels of income inequality compared to those who are more rural or smaller. And if I could go to the next slide. But to kick off this presentation, I'd like everyone to just take a second to think about this question and reflect. So the question is this: would you rather live in a world where your income is $50,000 and everyone else earns $25,000? Or would you rather live in a world where your income is $100,000 and everyone else earns $250,000? And if I could get the next slide, please. So now when we're thinking about income inequality, we need to understand sort of how it actually affects our health. There are three main mechanisms that are outlined in the existing literature. So first is a theory of social comparison. Now this occurs when you compare yourself to those who have less than you or more than you, and it may manifest in feelings of shame and ultimately poor mental health. As you may have noted, there are two other mechanisms here that are equally as important and they may interplay. So the next one is the erosion of social cohesion. Now, this is the idea that in higher income inequality areas, there is greater erosion of trust and connections between neighbors, friends, peers, and relatives, and so on, living in the same areas. So you may be less likely to go knock on your neighbor's door asking for a cup of sugar or something. And finally, there is also disinvestment in social capital. So this is the idea that in higher income inequality areas, there tend to be less investment and even divestments in training opportunities, health services, access to those services, and other important sources of social capital. If I could grab the next slide, please. Now, to go on to deaths of despair. Deaths of despair refers to those deaths that are attributable to drug overdose, alcohol-related liver disease, and suicide. Now, most research has also been concentrated in the United States, and there currently has been none on income inequality and deaths of despair within the Canadian context, at least when this study first came about. So deaths of despair are really important because they're large drivers of reductions in life expectancy with very high economic costs. What's even more important, or arguably more important than those economic costs, are the social costs that come along with having a death of despair in your community. So as it stands, deaths of despair are on the rise in Canada, with deaths due to substance use increasing by over 150% over the past 2 decades, and by 40% for suicide over the same time period. If I could grab the next slide here. So why would income inequality and deaths of despair be related? Well, we know that income inequality is a risk factor for substance use, for adverse mental health, and other societal factors. And then those same factors are associated with an increased risk of deaths of despair. Next slide, please. Now, if we can consider those same three mechanisms that I talked about previously, for comparing ourselves to others and so on, and those feelings of shame or less worthiness are really highly associated with other feelings such as isolation or even depressive symptoms, anxiety symptoms, and so on, which can thereby increase our risk of substance use or use of risky substances and even of suicide or self-harm. In terms of the erosion of social cohesion, that can make us sort of withdraw into ourselves and isolate, which is a really, really strong predictor of drug poisoning among people who use substances, but also a risk factor for depression, anxiety, and other items that may lead to increased use of substances associated with coping, but also with self-harm and suicide. And finally, we see a really important example of divestment in social capital when it comes to drug poisoning and drug overdose, given that in higher income inequality areas, sometimes, and at least in recent years, that there have been more closures of supervised injection sites or added barriers to needle exchanges and sort of social capital opportunities such as those. So if we can move forward here. So the main objective in this study was to investigate the association between income inequality and time to deaths of despair, specifically in Canadian youth. We could get the next slide. So why are we looking at this in youth? Well, mental health conditions are typically onset in adolescence and young adulthood. It's also a time of initiation of drug use and drinking, and youth might be particularly susceptible to drug overdose, given lack of experience, knowledge of drug poisoning, interest in risky substance, and lower tolerance. So suicide is a leading cause of death in youth, and youth are the second most common group or age group for experiencing drug overdose related deaths in the Canadian context. Now if we can move forward. So this study specifically used census data and death records from 2006 to 2019. Now our study was representative of the Canadian population under 20 years of age in 2006. So people in our study had the potential to age all the way up from 2006 to 2019, meaning the oldest person in our study by the end of the study period could be around 33 years old. Now, income inequality was measured using Gini coefficient, as I had mentioned before, and our outcomes included overall an aggregate category of deaths of despair, a category of just drug overdose, a category of suicide, and all-cause death. Now, alcohol-related liver disease, because this specific study was restricted to only youth, there weren't enough cases or outcomes of alcohol-related liver disease, as this tends to be an outcome that takes time over the lifespan to develop. And so, there are relatively few cases for this specific cohort. And if we can move forward. Great, so I calculated frequencies, proportions, standard errors, and so on to understand the sample a little bit more, and then employed multi-level survival analysis for each of these outcomes, and then further stratified these analysis by gender to determine if there were differences between men and women, boys and girls, and so on. So if we can move forward. So these are the demographics of our population. You see those are very large numbers because this was done using the census, right? So you see the majority of those in our cohort were male, just barely. Majority were non-immigrants, majority were in higher income brackets or income quintiles, and the majority did not report as being visible minority persons. Overall, at baseline, the mean age in our sample was 10 years, and there were, the average Gini coefficient within the areas that we were looking at was about 0.38, which indicates sort of a moderate level of income inequality. And the mean after-tax household income in our sample was $58,434. And moving forward here. So the results, what did we see? Well, essentially what we saw was for every one standard deviation unit increase in Gini coefficient, there was a 35% increase in deaths of despair, an increase as well in drug overdose, and also an overall increase in all-cause deaths. Now these models were of course adjusting for age, sex, ethnicity, household income, immigrant status, and those area level factors that I'd spoken on previously. If we can move forward. Now, just to visualize this just a little bit better, we see here that overall, some of these estimates, so for deaths of despair, for example, it's, that's about 1.38 increase in hazard ratio for those, like for higher income inequality areas. We see the magnitude is much higher for drug overdose, although the standard error bars are quite large just due to a limited number of events. We can see here that for suicide specifically, we are just marginally, it's, I don't know, you could still imagine that this might be sort of a clinically meaningful result where in higher income inequalities, there was sort of an elevated risk of suicide, but just based on the statistical significance, I cannot confidently say that this is true. And then for all-cause deaths, there was a difference. However, the magnitude is much smaller than that of deaths of despair, and especially for drug overdose. So moving forward here. Okay, so we have this information, and it's really interesting, but we realize that death really is sort of the worst possible outcome. It's the worst possible scenario. And all work on despair thus far has really been focused on death. So we think, what's next? We need to look at more proximal events, things that happen before the deaths actually occur. So we started a study on income inequality and hospitalizations of despair, just sort of a new term. If we can go forward. So the second objective here is to investigate the association between income inequality and hospitalizations of despair amongst Canadians. So essentially, we're using really similar methods, similar data sources, except using hospitalization data instead of that death data to see if the income inequality was associated with increases in hospitalizations owing to despair. We can move forward here. Now you'll see our population was fairly similar. We have marginally more women in this sample than we did of males. Again, this is of the general population, not just youth, right? So we see that the mean age in our sample is instead 42 years of age versus 10 in the initial study. The median after-tax household income is relatively similar at around $48,000 annually. And moving forward here. So here are our results. We can kind of see these similar patterns, except for this time we could actually look at alcohol-related liver disease because we had a higher number of outcomes occurring in the general population as compared to youth. And so looking at hospitalizations of despair, this magnitude is not that dissimilar from that of the deaths of despair study. And similarly, we see an increase in drug overdose, more markedly so than any of the other outcomes. And we also see that income inequality in general is associated with hospitalization. Now, that has been looked at before in the existing literature. So if anything, this more or less confirms that our estimates are pretty reasonable when looking at income inequality specifically. If we could move forward. Okay, so in terms of the discussion, essentially what we've seen is that higher income inequality is associated with deaths of despair overall, drug overdose deaths, hospitalizations of despair overall, hospitalizations owing to drug overdose, and all-cause mortality and hospitalizations. If I could get the next slide. Now, just to talk about some things, some sort of nuances in this study and things that we might be interested in. So first of all, I want to note that the term deaths of despair has been widely contested in the existing literature. Now, this is because there's sort of an implicit, like direct cause, right, between despair and death. And that's not necessarily true. So for example, we know that drug overdoses are most commonly caused by drug contamination with synthetic opioids or loss of tolerance after one stops using drugs and starts using drugs again, just for an example. So we know that these are not necessarily caused by despair when they could be caused by an accidental poisoning and so on. With that said, a lot of, in the existing literature, we understand that these outcomes are also not truly independent of trauma, stress, and despair associated with poor mental health and so on. And so this term is just used as a collective measure, but is not necessarily, like we should not necessarily consider that these outcomes are solely caused by despair. And finally, I wanted to talk about why we're really just seeing these results for overdose and not, say, suicide or alcohol-related liver disease. And this is likely because overdose can sometimes be more dependent on your physical and social environment compared to those other deaths. So for example, if income inequality is associated with isolation and loneliness, and isolation is a major risk factor for drug poisoning and subsequent overdose, because people are more likely to overdose or die or from an overdose if they are alone. right? And so that's why we might see a stronger association between income inequality and drug poisoning or overdose compared to the other outcomes. And if we can move forward here. In terms of the public health and policy implications, this work can inform decisions on income inequality related policies. So essentially, when we're thinking about income inequality, we're either thinking of giving people money to reduce income inequality or taking it away to reduce from the other side of things, right? So taxes, cash transfers, minimum wage increases, and so on. Now, those are sometimes contested in the political environment. So other ways that we can alleviate these issues would be from implementing greater mental health supports in higher income inequality areas, as well as drug prevention, but also harm reduction. So increase maybe supervised injection sites and things like that within spaces where income inequality is greater. If we can move forward. So finally, just to sum this up, and I know I'm a little bit over time, but to answer the question, would you rather live in a world where your income is 50 and everyone earns 25, or your income is 100,000 and everyone else earns 250,000? In a social experiment, some really prominent social epidemiologists did in fact find that the majority of people would select option one, where they earn $50,000 and everyone else earns $25,000. And that is income inequality. And next slide. Thanks for listening to my presentation.
Okay, thank you. I will continue from here with looking at the question, what we can do to address health inequality. So as we have seen in the previous talks by Brandon and Claire, we really see huge differences in certain outcomes also, and particularly linked to alcohol, that differ between socioeconomic groups or areas of different income inequality. And I would like to address now the question how we can use alcohol policy and specifically alcohol control policy to lower these alcohol-related health inequality in morbidity and mortality. And I will mainly refer to one publication, next slide please, which we have published last year, in which we summarized the international literature regarding the question how alcohol control policies can help to lower alcohol use in the general population, but also in specific population subgroups, such as different groups defined by socioeconomic status. When we talk about alcohol control policies, next slide, please, we first, of course, need to be clear what are alcohol control policies, and I like to refer here to the WHO best buys, so the best buys of the World Health Organization, that are the most effective and cost-effective policies to lower alcohol consumption in the population, and that are also effective in lowering alcohol harm. And there are three policy areas that are considered the best buys, and these are pricing policies, availability restrictions, and marketing bans. You can see them here right in the middle. Under each of this domain, we see again specific measures that can be adapted to, for example, increase prices of alcoholic beverages. These are pricing policies, and this could be, for example, alcohol taxation or minimum pricing. We also see policies that limit the availability of alcoholic beverages, such as spatial or temporary restrictions of alcohol products, for example. In the next slide, I will only focus on alcohol taxation, minimum pricing, and temporary restrictions, as these are the most effective policies, and they can also be implemented at the state and federal level. For example, spatial policies are usually implemented on a more local level, so I will disregard them from this presentation. Let's start with pricing policies, and next slide, please. I would like to start with the general idea of pricing policies. So how can we change consumption when we change the price? And this works through a policy that increases, for example, the alcohol taxation, and this causes an increase in the price of the alcoholic beverage. This, of course, is usually not a one-to-one translation, so sometimes companies overshift, for example, the tax, so the beverage price increases more than the actual tax, or it is undershifted. That means that the price does not increase to the full extent as the tax is increased. However, either way, if we increase our taxes substantially, we would assume to see a change in the price of alcoholic beverages, which again then will reduce the demand for the product. So people will buy less alcohol and therefore drink also less alcohol. Next slide, please. We have looked into alcohol taxation policies in our systematic review and meta-analysis. And it's important to say that we limited our study to only publications that investigated the direct effect of alcohol excise taxes on alcohol consumption. And we applied a rather strict definition to the study designs to allow for causal interpretation between the policy and alcohol consumption. And we identified 10 studies and found across these 10 studies that a doubling of alcohol taxes, so a 100% tax increase, would lead to an average reduction in alcohol consumption levels of about 10%. And this is what you can see here on the graphs on the right side. You see on the x-axis changes in alcohol excise taxes, and on the y-axis you see changes in alcohol consumption, both in percent. And you see a linear association we have identified in our models that displays the change in consumption given the change in excise tax. Next slide. Another policy is minimum pricing or minimum unit pricing. So this is a policy where we introduce a floor price on alcohol or a unit of alcohol. And we identified 4 studies in our review that reported then when introducing a minimum unit price, we see an average reduction in alcohol consumption by 12%. And the minimum unit pricing policies we were looking at were introduced in Australia and the UK, which were the countries where recently alcohol minimum unit prices were introduced. And in both countries, the minimum unit price were about the same level, that is about 0.9 international dollars. So this is roughly US dollar per 10 grams pure alcohol. And on the right side, you see these summaries from the individual studies and the average, weighted average across these studies. And what I think is quite interesting is that you can see, so every dot in this figure represents one estimate, and we see that the estimate differ between different beverage types. And we can see in the studies conducted in Scotland and Wales, the strongest reduction in alcohol consumption levels were seen for cider. And this is just because ciders were the cheapest alcoholic beverage before the minimum unit price. So for ciders, the price increased most, and this led to a more considerable change in consumption. So all these findings I just showed you are reflecting consumption in the entire population, the general population, disregarding any differences between sex or socioeconomic status, for example. But I want to talk about health inequalities. So how could pricing policy impact different socioeconomic groups differentially? And next slide, please. This can be achieved by a very important step in the mechanism I showed you, which I just disregarded purposefully, which is the aspect of affordability. So here we see that when we increase prices of alcoholic beverages, for example, through a taxation or a minimum unit price, not always will the demand be reduced. And this is because affordability. Affordability is not only a function of the price of alcoholic beverages, but also a function of the income. So if we have only a very small increase in the price, or if we have so much money that we just don't mind an increase in price, we will not change our behavior given the new taxation. So this mechanism, or this component in the mechanism, the affordability, may lead to differential impacts of a pricing policies across different income groups. Next slide, please. And this is something we observed indeed in Scotland. So Brandon was referring to this earlier already. So Scotland introduced a minimum unit price in 2018. And I brought you here a figure from a study of a colleague of ours. And you can see on the y-axis, the change in gram of alcohol purchased. And on the x-axis, you see on the left side, household purchasing fifths. And you see that the household purchasing fifths, so the household that purchased the most alcohol, they decreased their alcohol purchases most significant after introducing the minimum unit price. On the other side, on the right, you see household income fifths. And here it becomes pretty clear that alcohol purchases decreased most in households with lower income. So as suggested, lower income households are more likely to decrease their alcohol purchases and therefore their alcohol consumption after increasing the price considerably. Next slide, please. This is also mirrored in deaths and hospitalizations wholly attributable to alcohol. This is another study conducted for Scotland and the minimum unit pricing policy there. And what we can see in the highlighted box is that for the most deprived areas, deaths and hospitalization due to alcohol decreased significantly after introducing a minimum unit price. However, no significant decrease was observed in other neighborhoods or other areas that were less deprived. Next slide, please. There's also some evidence from other countries, for example, Lithuania. Lithuania is quite reasonable when it comes to alcohol policies because they introduced several policies, including an alcohol excise tax increase in 2017, in which they more than doubled their taxes on beer and wine. And this is a situation that barely happens, such significant increase in alcohol excise taxes. And what you can see here in this figure on the right is the trend over time of the inequality in all-cause mortality. So this is very important. The outcome that was looked at here is the absolute difference in all-cause mortality in lower versus higher education groups. So it's not just mortality of one group, it's already a measure of inequality. And what you can see is that over time, and this is just for men, the inequality in mortality decreased. And then there was a drastic drop, an immediate drop after introducing the policy in 2017, indicated by the vertical line, where the mortality inequality reduced by 13%. This effect was not observed in women, and also in the following years, so in 2018 to 2019, this positive effect on inequality was already nullified given an increase in the mortality inequality in subsequent years. However, what we can see is that for pricing policies, they really seem to affect socioeconomic groups differentially in a way that lower health inequalities that are caused by alcohol. So this is an overall very good and supportive finding to combat health inequalities related to alcohol use. Next slide, please. So how is the situation with availability restrictions? And I will focus on one policy that is a Sunday sales ban policy. So a couple of countries have previously banned, for example, Sunday sales, but then they allowed the sale of alcohol on Sundays again, or Saturdays. So 1 day in a week, alcohol sales were allowed or banned. And we have specifically looked into these policies. Next slide, please. So we identified 5 studies, and they were mainly located in the US and Sweden, and 1 study from Canada. And we observed across the studies in our systematic review and meta-analysis an average reduction in alcohol consumption levels by 3.6% when sales were banned on 1 additional day a week. And I have to say that we assumed here that the impact of repealing a ban and releasing a ban, or like enacting a ban, is the same, but in the opposite direction, to be able to compare these different studies. So the asterisk indicates reverse effects. Next slide, please. So how does it look when we just focus on socioeconomic groups? And here I have to say, although in our review, we really searched for literature on this, we weren't able to identify any study that had previously looked at differential effectiveness of Sunday sales ban on groups, for example, by socioeconomic status. So what we've done is to conduct our own study using a case that was Minnesota, where the Sunday sales ban was repealed in 2017. And I have to say, at this time, that is yet unpublished findings. So you will not find this yet online, but hopefully later on. And what we've done is to look into alcohol attributable mortality across over time for different sex and education groups. And what we found that with the repeal of the Sunday sales ban, there was an increase in the mortality among men with high education, but not among men with low education. We also observed that for men with medium education, there was also an increase in mortality, but it was less pronounced as in the group with high education, and we observed similar patterns, but again, less pronounced for women. So these first results indicate that there might be a differential effect, but in this case, those with a high education, so with a high socioeconomic status, are more likely to respond to the policy. And we have substantiated these results using data analysis, using survey data, which is less reliable, and we can draw causal conclusions based on this analysis. However, what we have seen is an association that is more pronounced between socioeconomic status, high socioeconomic status, and a Sunday sales ban on consumption, indicating again towards a higher responsiveness of people with a higher education when it comes to Sunday sales ban. So this is a finding which suggests that this policy is more likely to in fact increase inequalities if we seek, for example, to implement a new Sunday sales ban. So if we would implement a new Sunday sales ban, we would assume, given these findings, that people with a higher education might be more likely to reduce their alcohol use than those of low education. Deeper reduction in alcohol hospitalization in high educated group. However, I have to say, this is the very first study that had looked at this, and we are not yet at a stage where we can really understand what is happening here. So we are like research explaining why high socioeconomic groups may react to this policy different than those with a lower socioeconomic status. And this is obviously research that is now needed to really understand why we see this different impact. Next slide, please. Having that said, I would like to wrap up here. So what we definitely found is that alcohol control policies can impact alcohol use quite differently across socioeconomic groups, and this differential effectiveness can contribute to lowering health inequalities associated with alcohol use, as in the case with pricing policy, or they can even widening it. So, of course, our general aim is to lower alcohol mortality and adverse alcohol outcomes in the general population. So any alcohol policy that will reduce the overall burden is something we want to support. However, we need to keep in mind that different groups may respond to different policies in a different way, and this could lead to larger health inequalities in worst cases. And a last note I would take here is that we also need to keep in mind that alcohol control policies are useful to lower alcohol mortality, and they can help to lower inequalities. However, they cannot contribute to lower inequalities that arise from, for example, poor healthcare access or the exposure to other risk factors or any upstream mechanisms. So to really address health inequalities, not just related to alcohol use, we may also consider other policies to increase these factors for everyone. Next slide, please. And if you're interested in the research we are conducting, where we specifically look into the impact of alcohol control policies on health equity, I would like to invite you to visit our website at the KMH website. You can search for our projects there, and you can find upcoming results from our research, which we conduct here at the KMH in collaboration with the University of Sheffield and the Alcohol Research Group in the United States. Thank you.